So I'll be presenting a study which was presented in WCLC this year. This found to be a quite interesting study because if this clicks very well, probably many of our patients will be going on to this kind of a therapy. So this therapy basically is for the KRAS G12C mutant in first line. So this is something what we always wanted, and probably this is a ray of hope. And the this specific study focuses on the efficacy and safety of a new molecule, Olomorasib. This is a second generation KRAS inhibitor with combination of immunotherapy, that is Pembrolizumab, plus chemotherapy. So this is like three therapies together, a typical maximum combination what we can give in the first line. Uh, so basic background comes from the understanding that chemoimmunotherapy is used in first line NSCLC patients, especially patients who are having a negative molecular markers like EGFR, ALK, and they are also low and negative on the PDL1 expression, or the tumor burden is quite high and we need a good urgent control or a faster response rates. So these are the patients where we want combination of chemoimmunotherapy and get maximum response. So we have also seen combination working well as in FLORA 2 in patients who are EGFR mutant, combining osimertinib plus chemotherapy, and in some studies where even geftinib was combined with chemotherapy. So this combination of targeted therapy plus chemoimmunotherapy represent a very excellent opportunity in first line, because most of the studies which are available for KRAS are for second line and beyond. So if this is something which has a good potential and a good number of patients, as we know a good number of patients do have KRAS. So background comes from this study, the response rates, where the second generation Olomorasib was used, and they had an excellent overall response rate of 77%. So this was a favorable response with combination as a monotherapy and then in combination with Pembrolizumab. And later this was taken up into the phase 1 phase 2 study where they wanted to decide the dose, 50 milligram or 100 milligram. You can see there is a part A, B, C, D, E and G, and what we'll be focusing today is the part B9, where there is a combination of this second generation KRAS inhibitor with immunotherapy Pembro plus chemo. So this is what is the study what we are going to understand, and this is a small cohort, 21 patients. It took all patients who were treatment naive, PDL1 anything from 0 to 100%. It does allow, most of the trial now, new trials in lung are allowing one or sometime even two chemotherapy cycles, because we know that this agent, this NGS reports do come after 2, 3 or sometime even 4 weeks later. So practically when patient is symptomatic, we don't want to wait. In fact, patients or patients relative don't want to wait, and we do give therapy. So this is a very fair practical thing where they exempt giving 1 or 2 cycles, it is okay. And if patient has progressed like prior adjuvant or neoadjuvant therapy, then at least there should be a 6 months gap. So they did have 2 analysis dosages, 50 milligram and 100 milligram twice daily, and other things will not discuss here. So we'll directly come to the baseline patients. Here, as you can see, more than 90% patients were having either PDL1 low or negative. So these are patients who are having less than 50% of the PDL1, and 43%, so almost close to half the patients did receive 1 cycle of chemotherapy plus immunotherapy combination prior to the enrollment. Coming to the safety profile of this combination, patients did have anemia, a good lot number of patients, almost half of them, some grade of anemia, but luckily the grade 3 and above were less than 5%. Coming to the other hematological toxicities like neutrophil count, neutropenia, thrombocytopenia, leukopenia, they were also seen in almost 1/4 of the patient. And these were each of them, if we go for the individual drug, the Olomorasib was the only one which had 5% discontinuation rate because of its own side effects. Others are almost 10%. So this is a spider plot and the response rate, and you can see that the objective response rate was 50%. So half the patients are going to respond in a very nice way. And if we go for the disease control rate, so including the stable disease, it is close to 85%. So that's a good response in first line, as we expect in the first line, good response in the first line. And if we see the median duration of therapy, it was 4.5 months, and almost 3/4 of the patient did remain on therapy at the time of data cutoff. So what we conclude from this, that this combination of second generation KRAS inhibitor, G12C inhibitor with Pembro and chemo can be a potential first line treatment in this kind of subset of patients. The safety profile is quite manageable. We know how to monitor the hematological toxicities and how to manage the cytopenias. And preliminary efficacy is quite promising, with ORR of 50% and CBR of almost 85%. And this is a big chunk, almost 90% plus patients who are going to be having a PDL1 low or negativity. So beyond this, what they want to do is a phase 3 study, which is again looking for the global registration. And once we have that, probably this will open the door for next this kind of niche area where we want to do something in the first line. So this is something called as a Sunray 01 phase 3 study, where the combination either with 50 or 100 milligram and Pembrolizumab dose optimization. The safety led in part B will be the combination of all the 4 agents. After the dose confirmation, they will be randomized to receive either combination of KRAS inhibitor plus immunotherapy or immunotherapy alone, or the combination with or without the anti-KRAS. So I'll stop here, and hopefully in next 2 years or so we'll have the results for this, and probably we'll open the door for KRAS inhibitors also. Thank you for the patient listening.
Thank you, Bhavesh sir.